Good afternoon, everyone, and thank you for the organizing committee that's having me here today. It's an afternoon session, and after lunch, if you want to stretch a little bit for 1 minute, that's fine too, because this session is all about weight management. So my background is I'm an endocrinologist, and I'm specialized in obesity and diabetes. And today, I'm going to talk about weight management in a routine care settings. As we know that obesity is an epidemic, you can see it's affecting everywhere in the world. In some countries, in the blue here, you can see in the US, the prevalence of obesity is as high as 60 to 70%, so that's a lot. That's about 2/3. Even in Thailand nowadays, if you use a BMI cutoff of 25, our obesity rate is about 40 to 50% in male and female. What I'm saying is really an epidemic. You can see the obesity rate graph over here that it's been increasing since 1990 and up until now. We haven't found a way to effectively stop this graph yet, so that's why we call it's an epidemic. Okay, so I want you to think about it just a minute, that what's actually drive or what's are the reasons that really drive an epidemic of obesity that we are seeing here? Is it just the genetics? We changed our genetics over the past 30 years. Is it the food industries? If you go downstairs, you find a lot of food stalls, sugary drinks everywhere, bakeries downstairs. Is it about, our community transportation, or is it in the air, in the PM 2.5, or endocrine disrupting chemicals? So it's everywhere. What I'm going to tell you here is that, okay, you may have genetics predisposition, you have, DNA, you have epigenetic changes, but all in the air and everywhere can affect your body weight. It's the appetite changing in the hormones, it's the social context, it's your gut microbiota. We know the change in the bacteria, antibiotics affect your body metabolism. Sleep deprivation, if you're a shift worker, you're prone to gaining weight, obesity, type 2 diabetes. Endocrine disrupting chemicals, all the plastic that we use, medication-induced weight gain. ART is just a part of it. A lot of medications can cause weight gain. Stress, depression, lifestyle. So my message is that obesity can affect anyone, and it's really an epidemic right now. So my outline today, briefly, I'm going to touch about HIV and obesity. And my message is that obesity is a chronic disease, and it needs a long-term treatment and, of course, multimodalities treatment. So HIV and obesity, I think you guys sitting here knows more than me. Antiretroviral therapy, so some of them has more effect on the adipose tissues and metabolic syndromes and prone to obesity. Lipodystrophy is also part of it, the disease itself and the medication induced. Chronic inflammatory states, any disease that has chronic inflammation, even rheumatoid arthritis, psoriasis, and all that, chronic inflammations can lead to insulin resistance, and that can lead to metabolic syndromes as well. And other obesogenic lifestyle, as I mentioned earlier, those factors can affect anybody. Briefly about ARTs, especially the NISTI, you can see that the medication itself can affect adipose tissues at the adipocytes level. It can cause adipocytes hypertrophy and cause the adipocyte dysfunction. So adipocyte dysfunction and chronic inflammation, that can lead to chronic inflammation and insulin resistance. And the medication, some of that, such as PI, can affect at the mitochondrial level. So you have the mitochondria that is not burning. Instead of burning out calories, it's dysfunction. So that it causes insulin resistance even at the cellular level. And again, as I mentioned, the medication itself can change your gut microbiotas. This is the same thing as you're taking chronic antibiotics that change your gut microbiome. And that can lead to chronic inflammation, insulin resistance, and that's systemically causing weight gain. My message again here today is that I want you to look at obesity as a chronic disease. We look at diabetes as a state of chronic hyperglycemia. So obesity is a state of excess adipose tissue. And what causes diabetes is the disorders of glucose metabolism systemically. You have dysfunction, beta cells at your pancreas, you have insulin resistance at the liver, insulin resistance at your muscle, you have excess adipose tissue, you have your kidney dysfunction that absorb a lot more glucose, so that's the whole system, disorder of glucose metabolism. Obesity again as well, it's not just eat less and move more. A lot of things that I mentioned earlier causing disorders of energy homeostasis. A lot of things that disrupt your appetite at your hypothalamus level, a lot of factors that disrupt your adipocytes functions, your gut microbiome, your liver and all that, that's causing disorders of energy homeostasis, and that is called obesity as a disease. So that's why it's not easy to treat. So talking about energy balance, as I said, it's not just in and out, it's not just eat less and move more. Our body has a way to control our energy homeostasis, and the main function is at your brain. So your brain is here is kind of main center that kind of manage your energy homeostasis. Mainly it's in the hypothalamus, your arcuate nucleus. There's a satiety center and a hunger center. And all those centers receive signals from peripherally. Let's say from your adipose tissue, how much your adipose tissue is stored right now. They receive the signals from your guts, how much of the food is coming in, how much of your gut's hormone is right now, and then your brain will tell you how much you should burn and how much you should eat for your next meal. Okay, what I'm going to say here, it's easy to gain weight, but why weight loss is so difficult? So let's say our system here is very good. It's supposed to be keeping our body weight at the same level. When you're eating your food, again, just an hour ago, your food coming down to your stomach, it's go down to your intestine, you already secretes all those guts hormone, GLP-1, peptide YY, CCK, all those satiety hormones already going up. Right now it's going to your brain saying that food is already here, you should feel full, right? Next, leptin, adipokines, and all that from your adipose tissue. It's going to tell your brain how much you actually stored the energy in your body right now. Supposedly, our system is intact. What happens if you're trying to lose weight is that when you're trying to cut down your calories, you may lose 5 or 10%, let's say. Your body will try to burn less. From the graph here, you can see if you're losing 10 or even 20% of your body weight, your energy expenditure is going to go down. Your basal metabolic rate is going to go down. Even your physical activity at the same level, it's, your energy expenditure is going to go down. That's your body trying to conserve energy. Your fat mass is down, your leptin level is down, right? You're going to feel more hungry. And this is a study in a person who's trying to lose weight for 1 year. And they measured all the guts hormone, the ghrelin, amylin, and all that briefly. After 1 year of weight loss, your hunger hormone is going to go up and your satiety hormone persistently down. So all in all, that's a perfect storm of yo-yo or weight regain. A lot of people trying to lose weight and then they regain them back because their body going to fight back, they're going to burn less, and they're going to make you feel more hungry. So this is a natural history, right? Your body defense of the weight loss. It will try to make you come back to your highest weight. So this is my routine practice. When I see a person coming in, I assess, the degree of obesity. We use BMI. We do in-body measurement of the percentage of body fat mass as well. And then I assess obesity-related comorbidities, diabetes, obstructive sleep apnea, and all that. I try to look for secondary causes. Is there any medication-induced weight gain? Any lifestyle factors? if there's anything that I can modify, I'll try to do as much as I can. But of course, I'm not going to go back and say, hey, please change your ART regimen. No, I'll leave that up to you guys. Okay, so obesity treatment modalities, of course, is consistent of lifestyle management, weight loss medications, and interventions such as endoscopy or bariatric surgery. And the approach is here. So lifestyle modification is for everyone, even you're at a normal BMI. So lifestyle modification, it should be implemented for everyone at any BMI. Okay, let's say your BMI is already high. You're trying to lose weight, you cut down your calories. Okay, let's say you're trying to eat 1,200 calories or 1,500 calories. How do you think you're going to be full on the 1,200 cal a day? It's very difficult. So that's really a problem of going on a diet. How do you manage your hunger, right? Your body trying to fight your back with the hunger hormones and all that. Okay. So now we know that we need to cut down calories, but then you need to be full, right? So this is my quick tools for my patients, but I send them to my dietitian as well. But the quick tool is that you're supposed to be full on a good food, and that is high protein, high fiber. So high protein, high fiber, that's give your satiety hormones, it stimulated GLP-1. And then high fiber, of course, you have vitamins, nutrients, and all that. So you're gonna feel full on a less calories. But if you keep eating high dense calorie food, you're drinking a lot of sugars, even though you're taking in 3,000 calories, you're gonna feel hungry all day. Okay, so that's the key. If you're taking in just sugars, no matter what, you're gonna feel hungry all day because sugary craving is there. Tools here, I think it's easily to use. It's a meal replacement. There's a lot of commercial meal replacement out there, or you can use a medical formula as well. So the concept here is that you calculated that they're taking in enough proteins, fibers. You may supplement a little vitamins here and there. So most of the meal replacement decide to be used 1 or 2 meals a day, and then plus, another sensible meal, which is high protein, high fibers. This is a comparative of meal replacement versus just a usual dieting program. So meal replacement can give you up to 10 or 12% weight loss. This is a direct program that a weight management in type 2 diabetes in primary care clinic. They use a total meal replacement. And you can see here, patient drop down body weight from 100 to 85 kilograms. So that's equal to about 15% weight loss. But you can see here, after they stop doing the meal replacement, they titrate back to a healthy diet. They're still gonna gain their weight back. So my point here is that any type of diet, even if you go on an extreme diet, meal replacement, very low calorie diet, but once you stop doing it, your body gonna, regain back all those weight. Right? So what is the best strategy to prevent weight regain? Okay, is it a protein diet? Is it high fiber? Or drinking lots of water pre-meal? Or exercise and weight training? Actually, all of it here. So the best formula to prevent weight regain is high protein, high fiber diet. The worst one is low protein and high glycemic index. Okay, so that's the worst thing you can do is drinking a lot of sugars and not eating protein. Drinking lots of water is good, and also exercise and weight training, because your muscle is, the biggest organs that will consume your energy. Your muscle is the one that determines your basal metabolic rate. So please love them forever and start taking care of them since today. Okay, so you're going to eat high protein, exercise every day, keeping your muscle mass, and that's very good for long-term weight management. Okay, so we're doing a lot of things, but if you're starting off at a higher BMI, even with an extreme diet, 10 or 15% may not be enough, right? You probably need something to help pushing them further. So that's coming down to pharmacotherapy. Okay, so I usually point out this efficacy treatment to my patients. Depends on their goal, how much you want to lose weight. You know, you want to lose or 5 or 7%, or you want to lose up to 20% or even 30%, that you probably need bariatric surgery, right? So kind of layout, as I mentioned, meal replacement or extreme diet, up to 15% weight loss. Weight loss medication, with the newer agents that is available in the US, tirzepatide, that can be up to 20% weight loss. But if you need more than that, of course, 30% weight loss, the only option is bariatric surgery. I also tell my patients, when setting up a goal of weight loss, which comorbidities you want to achieve remission. Let's say you want to improve your obstructive sleep apnea, 5% weight loss is not enough. You probably need more than 10%. If you want to achieve diabetes remission, that's probably 15% weight loss. 5% weight loss, yes, it may improve your glycemic control a little bit, but it's not enough to achieve a remission. So kind of lay out, so setting a goal with your patients, how much they want to lose and what kind of options that will get them there. In terms of medications as of nowadays, they are all appetite suppressant. So it's supposed to be used with lifestyle modification. They should know first what's supposed to be eating, and then you added an appetite suppressant so they can be better adhere at their lifestyle changes. Some of the oral agents are available in the US and Europe, but in Thailand we have only GLP-1 injectable available. But I think we are in the era of GLP-1 receptor agonists here. GLP-1 is the gut hormones that have multiple actions. We use it for diabetes treatment because it stimulated insulin secretions, it suppressed glucagon secretions, but then we use GLP-1 for obesity treatment because it acts two places. One, at your brain, because we have GLP-1 receptor at your arcuate nucleus. It's going to go to your satiety center and tell you to feel full. Secondly, it acts at your stomach and your intestine. It's going to slow down gastric emptying. So the amount of food or the volume of food that you can tolerate going to be less. Let's say without GLP-1, you were eating, your stomach can go up to this. With GLP-1, your stomach probably go to this and then stop moving, and then you are full. Okay. So several GLP-1 receptors available nowadays. We have liraglutide, which is the daily injection. We have semaglutide, which is the weekly injection. And we have tirzepatide, which is a co-agonist of the GLP-1 and GIP hormones. And the efficacy is kind of laid out here. And there's a lot of medications in the pipeline as well. So hopefully that's the cost going to go down in the near future. Here is the semaglutide 2.4 milligrams weekly for weight management. You can see in the treatment arms, weight loss is about 15% compared to the placebo arm. The weight loss is about 2.4%. This is the tirzepatide once weekly. The weight loss here with the highest dose, 15 milligrams, it's 20% weight loss. So that's really a very impressive. A little tips here about GLP-1 receptor agonists. It needs a titration, no matter forms you use oral or injection or whatever. GLP-1 receptor agonist, you need titration dosage, because if you're going up too fast, patients going to experience more of the side effects before they're going to reach the dose of the efficacy. Okay, you're going to go slow and needs titration. Weight loss doesn't happen overnight. So, I kind of set goal and then tell my patients what's going to happen as well. That, your fat mass is going to change overnight. It takes weeks and months. So just focus on the details, what you're going to do on a daily basis. You use your medication, you eat protein, you exercise and all that, focusing on the details, not on your weight on a daily basis. If you're doing the details on everyday right, your long-term outcome is going to be good. Expect to see various results. I think this sentence is for any weight management treatments, even lifestyle modification, weight loss medication, or bariatric surgery. You can see a waterfall plots on any study. You'll see a patient who lose a little bit, a patient who not losing any weight, a patient who lose a lot of weight on treatment. So it just tells me the heterogeneity of the disease of obesity. That's it. So sometimes patients coming in, oh, my neighbors lose a lot of weight. She lose 20%. I'm like, okay, just wait and see how you're doing, right? With the weight loss medications, if it works, continue. Because obesity is a chronic disease, right? It is the same way as you treat hypertension, the same way you treat your glucose or your lipids level. If it is at goal, you continue your treatments. If you stop your treatments, your weight's gonna go up. Same thing as your blood pressure pills. If you stop taking it, your blood pressure is gonna go back up. Same thing, it's a chronic disease. GLP-1 and SGLT2 receptors. Here's a study is published in ADA journal, Diabetes Journal. Is the use of GLP-1 and SGLT2 inhibitors in a person with HIV and type 2 diabetes, and they look at the cardiovascular events compared to metformin. So in endocrinologist background, we know that GLP-1 and SGLT2 inhibitors is a very good medication for cardioprotection for patients with diabetes. And you can see from data here, I think it's the same thing in people without HIV. So benefits is still there. GLP-1, SGLT2 receptors, it's reduced heart failure, myocardial infarction, and cardiovascular events. Here is a study on semaglutide in people with HIV, but this is it's a cohort, so there's a variety in this study. It's a retrospective cohort, so there are patients with or without diabetes here, and some of them use a low dose of semaglutide, some of them use a high dose, but all in all, the treatment with semaglutide, in people with HIV, they still achieved the weight loss 6.5 kilograms. I think it's pretty much comparable in even people without HIV. So expecting to see the same response. This is a study of semaglutide, but it's a low-dose semaglutide in HIV, people with HIV with NAFLD insulin resistance. It's the Slim Liver study. I think next speaker may cover more on this one, but again, semaglutide help with the weight loss, decrease visceral fat, and same data as you expected in a non-HIV person. Last but not least, bariatric surgery. We know that bariatric surgery is a very effective treatment for obesity. Even sleeve gastrectomy or Roux-en-Y gastric bypass, that can cause up to 30% weight loss. So it's still very useful on a patient starting off with a very high BMI. Let's say you have a BMI of 45 and you use weight loss medications that get you about 10 or 15% weight loss. Your BMI is still going to be in your 30s, right? It's not in the safe zone yet. So if you're starting off with the high BMI, above 40, bariatric surgery, it's still a very good option. Here's the pro and cons. So this is the conversation that I talk to my patient. You're going to lose a lot of weight. What's the benefits? The cons. Okay, what else you have to do? You have to take vitamins forever in your life, but then you get rid of your diabetes medications and all that. So this is a discussion that I talk to my patients. At our center, we did a lot of bariatric surgery each year, and over the past 10 years, I think we did a few, maybe up to 4 or 5 bariatric surgery in people with HIV. Several concerning issue here because if you do a Roux-en-Y gastric bypass, we're very concerned about the absorption of the medication. So we have to look through, okay, which procedure of the surgery that we're going to use, If it's Roux-en-Y gastric bypass, which medication they're taking, the absorption site, if it's duodenal or jejunal, is it the site that we're going to bypass? Does it need pH dependency and all that? So it's a discussion with the bariatric team, me, myself, and also my ID colleagues, whether, the regimen changes and all that. But again, briefly, it is safe and still very effective treatment. Just, take a look at your medication regimen and just double check that it's okay for surgery. Here's several cohorts: bariatric surgery in people with HIV, 5-year outcomes in the tertiary center. I think it goes along the way. The efficacy of bariatric surgery is still there, and we can manage it safely as we do for everyone. Okay, my last slide. Just want to let you know, obesity management is kind of here. You have lifestyle modification, which is your fundamental. That's my bottom line. Lifestyle modification is still your fundamental treatment. And then if you go up the pyramid, if you have a good fundamental, you're going to be successful with your obesity treatments. Thank you. That's my last slide here. I don't know if I have a few minutes for questions and answers. Thank you.